So I might kick off, and for those who are still joining, I've said there's a number of people still to come, so I will talk slowly to give everyone time to join. But I wanted to start by welcoming you all to our webinar on Victoria's virtual care programs. And this is being put on behalf of Deliver, which many of you will know is a research program funded by the MRFF, led through Western Alliance in Victoria's southwest, and with all the different health services and the primary health network involved. This is a really fantastic opportunity for all of us to hear from both the state government and also one of our research leaders in the area. I wanted to first start with an acknowledgement of country and pay my respects to the original owners of the lands that we're all working on. For me, that's the Wurundjeri people of the Kulin Nation, and particularly to pay my respects to Aboriginal and Torres Strait Islander elders, past, present and future, and any Aboriginal and Torres Strait Islanders who might be present with us today. I also wanted to give a big thanks to Kate Huggins for organising this webinar for us, and also being so flexible when we had a personal mishap with the previous speaker. So thanks to her and to all of you for rescheduling to today. And also particularly to our speakers. We really do appreciate Chetna and Amelia coming from the Department of Health, and Olivia to share her research insights with us all. We are recording the webinar for people who couldn't attend today. So if you have any problems with that, please let us know. And we will have time for questions after each of the speakers. And so we would ask you either to put questions in the chat as we go, and Kate and Peter Kelly will kind of monitor those and bring them back when we have the time for question and answer, or you can just put your virtual hand up when we get to the question and answers. So I'll leave that up to you. So I'm going to move straight on to introduce our first speakers. So Chetna, Soni and Amelia Matlock work in the Office of the Chief Digital Health Officer in the Victorian Department of Health, and their work areas encompass the digital health strategy and virtual care. So we're really lucky to hear from you today, and I'll hand it over to you. Thank you very much.
Thanks, Anna, and good afternoon, everyone. Thanks for making time on a Friday to come and listen to us. Hopefully, we won't take too much of your time and ramble on, and leave plenty of time for questions and any comments as we kind of navigate through. I am going to start by trying to share my screen. Zoom is a bit alien to me, so please allow me a little bit of flexibility and let me know once you can see what I can see.
That's come through now, Chetna.
Lovely, thank you. So before I begin, I too would like to begin by acknowledging the traditional custodians on the lands on which we meet today, and pay my respects to elders past, present and emerging. So I thought before we delve into virtual care, we may just give you a little bit of an intro of the work that Amelia and I lead. So I lead digital health strategy for the digital health branch in the department, and work with Neville Board, who is our Chief Digital Health Officer. And part of my portfolio in the department not only includes virtual care, but also a focus on rural and regional, metro health services, as well as research, innovation, e-health safety, and a lens on our national program. So quite a broad range, a small but mighty team, but we do try and cover a lot where we can. And Amelia is our lead for virtual care, but I'll allow her to introduce herself before we jump in.
Thanks, Chetna, and thank you, everyone. It's nice to see a couple of familiar faces or names on the screen as well. So I joined the digital health branch in November, having come across from a background of paediatric nursing, and then moving into health service project management, including leading the e-referral project at the Alfred, which some of you may be familiar with, and really enjoying working on these next steps to help bring virtual care into a streamlined process for the state.
Great. So Amelia and I are going to tag team today. So I'll take the first half of the presentation, and Amelia will do the deep dive into virtual care. But I thought I'd start off with really just providing an overview of Victoria's digital health roadmap, which is really our guiding post for how we improve the safety and quality of healthcare across Victoria. And it is broken into kind of 5 areas, stacked up quite purposefully from 1 to 5, as we hope to kind of mature our digital health journeys across the health sector in Victoria. So program of work area 1 really talks to the foundational layer that we put on top or put underneath really on all of our digital applications. And it really speaks to how we continue to improve that resilience against technology outages and cyber attacks, are really the non-cool stuff, but very important to kind of deliver in terms of the tech and the kit that is offered to health services to ensure that we're running a safe and secure and highly reliable service. There's a lot of work that we've done over the past few years to kind of help bolster that, and I'll run through some of that in the next few slides. And then moving on from that, the next kind of pillar on top, or the next layer we kind of lay on top of that, is how do we reduce the risks to patient safety? So moving off paper based care processes, as many of you may be aware, and we're not aware, but about 60% or 60 to 66% underway, or 60% completed, and the remainder of the 6 kind of underway in our digitization journey. We still have a fair way to go to close that gap between paper and moving away to a completely electronic and paperless system. So there's still some work that we're doing there, and working with our health services and prioritizing those needs. And then really program of work area 3 of what we call connecting care as well talks around how do we then, once we have those foundational layers of a secure, reliable system moving off paper, how do we start to join up those journeys and make that care journey seamless for the consumer, as well as providing a good experience to our clinicians as well, working out at health services. And that really is our largest program. It really speaks to the work that we do. For My Health Record, it really speaks to the work that we do with HIE, health information sharing, e-referrals, e-prescribing, whatnot. So it is outlined in our roadmap quite succinctly there, which I will share the slides later, but it is linked here. And then program of area work 4, which is where the focus of today will be, is once we've got all of those foundational layers and we've connected up the journeys, is how do we elevate that care to deliver virtual care and really drive that care closer to home and outside of those brick and mortar hospital walls, and really trying to get that going across our health services as well. So that really the first 3 programs really underpin those foundational kind of elements before we get to that virtual care, noting that a lot of our health services, I think we're probably at different levels of maturity across the system, but I think that's the beauty of our devolved governance in Victoria. And then lastly, is probably the nirvana that we all want to get to, is giving consumers access to their own health information. I think that's probably a very real and really relevant expectation of our consumers today, is really what is happening with their healthcare, giving them access to via patient portals, so they can view their own medical records, test results, whatnot, request their appointments through a safe and secure portal, allowing them as much autonomy as they can to navigate their healthcare journey. And using that roadmap, we kind of do try and see how we are in terms of maturity level. So we do have a maturity assessment model as well in Victoria. And probably, I think, benchmarked, we're probably between 1 and 2 for rural regional, and between 2 and 3 for metros. We have run a recent assessment. Hopefully we can share some of those results in the near future as well. So this is just a schematic and a visual. As you can see, it is quite a wiggly line to get to that nirvana, but it is really important that we take that step-by-step journey to ensure that we're delivering that maturity across the system. Moving on, in terms of our strategic priorities, like I mentioned earlier, transitioning off paper is what we're calling the last mile of digitization of our remainder of our health services that are still, unfortunately, working off this diagram here, where we've got piles and piles of records and paper records to kind of sift through, is one of our main priorities. And secondly, as many of you would be aware, in March, we were successful in, the government passed through the Health Information Sharing Legislation Amendment, which now allows us the legal kind of underpinning framework to actually start to connect up those care journeys through the implementation of the Health Information Exchange and that secure sharing of clinical records at the point of care, which is incredibly important, specifically when we're talking about virtual care. The person delivering your care should know more about you rather than kind of flying blind. And then thirdly, obviously, safe extension of virtual care. The pandemic, I think, really accelerated that within Victoria, and it really is, how do we now make use of those gains that were achieved, and how do we safely now work with health services and the sector to safely extend those models of care and continuously kind of evaluate them as well. And lastly, citizen access to their own health information. Again, I think partly accelerated by the pandemic, but also partly accelerated by I guess the consumers that we have today out in the system, and I think it is a very real expectation of consumers to have some access to their health information. So those remain our priorities. In terms of, like I said, the foundational layers and some of the really, I guess, not so cool work that we've done over the last few years, again, but very critical and foundational to getting us to where we are today. And outlining some of the programs is really around, if you look at unique patient identification, which also was a recommendation of Targeting Zero, we have purchased the NextGate Enterprise Master Patient Index, and it has been implemented across over 90% of health services across Victoria. That really is incredibly important as consumers move across different care systems and move across different health services, to have one unique kind of identifier that does allow us to identify their health information when it does eventually even go into the HIE, for example. Messaging engines, again, just uplifting the legacy JCAPS engine to a more contemporary Rhapsody. It just makes the world of difference when you're sharing images and sharing notes and sharing pathology results. And it obviously has a lot more redundancy and reliability across as well. So we have worked extensively with health services to uplift those messaging engines. And as I mentioned before, the purchase of the health information exchange that was enabled initially by the pathology and mental health reforms, but now through the passage of the legislation, really is our critical program of work that we are very busy with and working across the sector to ensure that we've got the right foundational kind of skeleton in place before the legislation is enacted in February. Clinical grade area-wide network, again, it's a fancy name for poles and wires, really. It really is around how we provide a lot more redundancy and reliability again into the system with a fast, wide area-wide network. Makes a world of difference when you're sharing clinical images and notes and securely across health services. And then a lot of work has gone into our cyber program. So we almost have a single glass plane view of our threats, and we operate a 24/7 incident management team supporting health services should there be threats or interventions that we do need to take notice of. And lastly, the Disaster Recovery Service is a program that's still underway, but again, providing health services a fast, reliable failover mechanism so that should things do fail over, you are able to recover within a timely manner with the right information that allows you to, I guess, bolster your business continuity as well. And I'm probably not going to dwell too much on this slide because I feel like I'm going to preach to the converted, but really all of that makes a world of difference to clinical safety and access to specialist care. As we all know, digitization improves safety and continuity of care. It shortens the time to diagnosis. It's foundational for everything that we deliver across the health system. And it is absolutely, and there's piles and piles of literature, as I'm sure most of you are aware, on how it is a lot more safer than delivering care based off paper-based records as well, and reduces errors and enables that specialist diagnosis as well. Now I'm going to throw over to Amelia to take us through the next lot. And Amelia, I'm happy to be your slide buddy here, so let me know when you want me to flick over.
Excellent, thank you, Chetna. So in this part of the talk, I'm really going to talk about some of the work that's been happening over the last 12 or 18 months. And a lot of it you'll recognise from the work that you've all been doing yourselves that has been generated, some of the initiatives have been generated out of the work that came from as a result of the pandemic and the responses that we had to mount to be able to continue to deliver care safely to the consumers whilst meeting the requirements, you know, to keep the state safe as well. So some of those programs, just to give you an example, that have really started to take off, that had their infancy in in that COVID period is the Better at Homes program. And so Better at Homes program has really enabled the health service partnerships to leverage the virtual care models that are in place to be able to deliver deliver care for those consumers closer at home through targeting cancer care, GEM, rehab, and post-op surgical care. The VVED, which I'm sure you're all very familiar with, it certainly got a lot of coverage in the early days of the pandemic, was stood up initially to ease the pressure on the health services emergency departments to manage some of that triage of patients presenting with COVID symptoms. And the success of that has actually enabled that to be one of the programs that we've been able to implement across the state. And so that's certainly something that has really shown the way for us, being able to provide safe and effective care that's providing benefits for both the consumer but also the health services in alleviating some of that pressure at the front door of the emergency department. And I think I almost need these models of care to be around the other way, because I think, you know, the initial birth partner of all of this was the COVID positive pathways, and that actually came out from some of the initiatives that were generated within the health services that really showed us that there was a process and a requirement to provide some standardised care and virtual care for patients to be able to manage their symptoms and create alerts and triggers for the health services to be able to act upon in a pretty streamlined fashion, whilst enabling access and equity across the state, so that it wasn't health service dependent. It was a process that everybody across the state could be involved in. Thanks, Chetna. So before my time in 2022, as a result of the Health Services Summit, virtual care was clearly identified as a priority area for the department and for the health services to work on. And as a result of that meeting, or the summit in 2022, there was the virtual care CEO working group was stood up, and they were a time limited working group of some really engaged partners who really, as a result of that, provided some direction and generated some artefacts for us to be able to continue to meet that priority goal. One of the first things that we did was really undertake a bit of a landscape survey of what was happening out in the health services. And as a result of that landscape survey, you know, really started to understand that there was a breadth of models of care. There was over 40 models of care in practice being utilised across the state that really covered the continuum of care. As we mentioned, the VVED really responded to that urgent care need and enabled people to either make a self-referral, provided referral options for aged care facilities or care in the home, and a secondary triage perhaps for some of those rural and regional health services to tap into their metro partners to provide some guidance there. The acute sector really has started to take off with that funding through the Better at Home program, and we're seeing the benefits both for patients and for health services, with the ability to provide an earlier discharge but also care closer at home for people so they can continue to have care at home for things that would otherwise potentially require admission. Post-op, I think, you know, most health services now are really familiar with that early discharge program of post-op, and then some virtual care to ensure that the patient's meeting the requirements to continue to recover safely at home. The infant or the beginner was the outpatient program, and that was through setting up that telehealth, which everybody will recall in the early stages of the pandemic went from a very small program to rapidly being increased to all of the specialist outpatients, consulting appointments, allied health to being provided by telehealth. And I think that enabled the consumers also to really develop an understanding and acceptance of virtual care as part of their care journey. So it's had benefits, I think, that we're still receiving today. And perhaps one of the biggest growth areas, in the future is going to be that integrated care to manage and assist manage chronic disease management, enable people to remain at home through and manage their care through remote monitoring, but still tap into their specialists and primary care team. So as I mentioned, the Virtual Care CEO Summit generated this working group. The initial artefact that was developed out of that was a set of 8 principles for providing virtual care that they felt were the requirements for a health service to safely provide virtual care. And as a result of that, that then naturally led into the development of the operational framework, which is almost released. I think we're waiting for that. We nearly had it released, and I have been promising that to the telehealth COP. So I'm hoping that that will be something that we'll be able to share with you very soon. But essentially, the virtual care operational framework is designed to enable or to assist health services to measure existing, or when they're standing up a new virtual care program, against some fairly standardised requirements or guidance. So it covers, and it's got a checklist at the back with more detail, obviously in the document, but clinical governance, the requirements for digital technology, the process for partnering with consumers and what that should look like, supporting the workforce to develop digital capability, ensuring access and equity across all of the consumer groups, and also for health professionals, and then that process of evaluation and continuous improvement to ensure that it's being measured and the service that's being delivered continues to meet those guiding principles. So that in itself was a fantastic document, but we then felt that, or the CEO working group obviously felt that whilst we had the digital roadmap, that perhaps we also needed to align a virtual care strategy to sit alongside of that, and that's really aligned with the virtual care operational framework and the roadmap to provide a 5-year vision around the pathway to integrate virtual care into the healthcare delivery systems within Victoria. It addresses 4 main pillars, which are safe and effective virtual care experiences and outcome, boosting the workforce supports, strengthening our virtual care enablers, and driving innovation to improve virtual care. So you can see it does sit nicely in between the work that Chetna was talking about with the roadmap and then that operational framework. Thanks, Chetna. So there, I think that really covers off perhaps some of the documentation and strategic work that's been done, but it hasn't only been a focus on that. Many of you would know that we do have the statewide funded platform of Health Direct, and there's been some really innovative work to leverage their capability in the remote physiological monitoring space as well, to really understand what they're technically capable of in terms of assisting the health services to provide some of that remote physiological monitoring that will be the next growth phase for virtual care. So we've had some great successes in developing technical capability, and we've been able to prove that we can send through live or real-time physiological monitoring results from a patient to a clinician at a health service, or from a GP in a consult back through to the health service as well. And we've been able to do that with both SATS monitoring and a 5-lead ECG that can also enable SATS monitoring temperature and blood pressure results to be read on the screen. The next step for us is, we've developed that technical capability, but now to really work with the health services to understand that we've proven that we can do it. What are the use cases and the clinical utility, and where should we point the next stage of development for this capability to provide maximum benefit across the state to all of our users?
Great. I may jump in here, and conscious of time, in terms of kind of obviously where we're heading, I think this is really just a small recap of what we're trying to do internally with the department in collaboration with the sector. But like we said, our focus does remain on getting hospitals off paper, health information sharing, and that expansion of virtual care, and also then building on our remote monitoring capabilities with our partners in Health Direct as well. So I'll stop here and take any questions if there are any.
Thanks so much to both of you. That was such an excellent overview, and I can see everyone's brains working in their own direction. So I'm sure there'll be a few questions. Who'd like to kick off? As I was saying, just pop your virtual hand up or put a question in the chat if you like. While you're thinking, I might just ask, in terms of the sort of maturity assessment that you've done and an audit of all the programs that you're talking about, when do you think you might be able to share those things? Because that is something we're obviously very interested in, the rural and regional areas, and particularly thinking about smaller rural hospitals.
In terms of the digital maturity model?
Yeah,
I'll take that on notice and come back with some timelines on what and how we can share some of that information. We have been, health services do get their own assessment. We just haven't worked out a process that we can make that publicly available just yet, but that is very much on the radar. So I'll come back to you on that, Anna.
Great, thanks. Jo.
Thank you. That was a really interesting presentation. I've got a question around the unique patient identifier and whether or not that is in place in Victoria, or is it still on the way?
It is very much in place. I think we've got a couple of health services yet to target. I'm not sure which health service you're from. It could be one of them. But it is very much in place across more than 90% of our health services. So it does work in the background. So it's probably not as upfront in terms of its kind of use, but it does link in with your patient administration systems and other kind of other applications that you do use across the health service.
So the question that I have is really in regard to like VEAD data and the data that is sent to VAHA, and is that using that identifier, a single identifier?
No, not at this point,
Okay.
Jo. So that single identifier is really more operational for consumers as they navigate. So kind of giving like a unique number to Chetna's details if it's ingested by the HIE, for example, but it's not used in VAD yet.
Thank you.
Other questions? Got a couple more minutes. Yeah, Debbie.
Thanks, Anna. Hi, Amelia and Chetna. Thank you for your presentation. Lower my hand. Here we go. Quick background, just to introduce my questions. I might have contributed to some of the work before the work that you were reporting on. I was part of the Victorian Healthcare Recovery Initiative, where we surveyed what were the virtual care programs that were carried out around Victoria, both prior to COVID and also in response to COVID. And at the current time, as part of Deliver, I'm doing some service mapping for health services around Victoria with a focus on home-based care and telehealth. And so I'm seeing some of the stuff that you've just reported, which is when health services have that telehealth page with all the links to the telehealth services, it's always Health Direct supported. It's fairly clearly labelled. You know, if you want to look at your allied health outpatient, that's where it was. If you want to look at inpatient specialist consults, that's where it was. But as I'm doing the mapping, starting at the larger, more regional health services, moving into the smaller ones, we're starting to see where there might not even be a telehealth page at all. That's not to say they might not. That's not to say they won't offer telehealth services completely. That could still be an option. I'm just not really seeing that on the websites. But finally getting to my question is, as part of Deliver, because we want to push for better care at home, which most likely is going to rely on telehealth and virtual care, when we do go to these health services and make suggestions that are inevitably going to include telehealth, how much do you anticipate that the department is able to support their adoption or transition into telehealth? And, you know, how much can we offer them when we cite the department as a close partner?
Yeah, I may jump in and then I may ask Amelia to jump in, and given her close relationship and management with Health Direct. So Health Direct is a state-funded service. We do have a community of practice to kind of guide the adoption and kind of ongoing use and monitoring of that platform. And from my understanding, it is available across all health services, community health organizations. And I think we're stretching ourselves beyond some of those centers as well. And Health Direct do offer a fairly comprehensive kind of onboarding program, but I may just defer to Amelia for some more details there.
Yeah, no, I think you've covered at a high level, essentially, Chetna. What happens if you do have an organisation that doesn't appear to have telehealth capability set up with Health Direct? The process to get them on board is relatively simple, and Health Direct is set up to provide the training and the onboarding for those health services to help them not only learn how to utilise the technology, but also to set up their clinics and waiting rooms and all of those sorts of things. So we can definitely support them on that process. And of course, you can always shoot me an email now that we've met Debbie and link me in, and also I can connect that person in with the COP that runs every month and is a really good forum for all of the users to connect and bring up discussion.
Thanks very much. Jo.
Hi, g'day. Sorry, this might be a little bit off centre. We are a small rural health service out at Edenhope. We provide supported telehealth with the RN, but we're actually finding on our end, the platforms are all great, but the specialists don't want to engage in it anymore.
Yeah, and I don't think that's unique, unfortunately, to your health service as well, Jo. I think that is unfortunately probably a reality across even some of our large metros as well. And probably a real challenge that some of our telehealth coordinators and program administrators, when they attend the COP, do navigate. If it does help, we're happy to kind of extend that support of the COP in terms of coming together. It really is that learning health system that we're trying to create with the community of practice to help support and overcome some of those barriers as well, and what's worked and what's not worked well across other health services, if that's of use. Amelia takes the lead on that COP, so very happy, and I'm just going to dob Amelia in, but very happy for you and Amelia to connect, and we can make those linkages there.
That'd be great. That was actually the topic. I can see Michael on the call. That was a topic of discussion at our last COP on Tuesday, actually, was around stakeholder education and engagement. So really happy to have a chat with you and connect you in.
Would love to be involved. Thank you.
Can I just ask a really naive question off the back of Jo's point? So joining this COP or being a member of this COP, is that broadly available to all health services, or would most people need a special invitation? Or so in our conversations, what's the framing there?
Yeah, so most health services that do use Health Direct do have either dedicated telehealth coordinators, or it could be someone who kind of does manage that service, and it is open to health services that do have Health Direct and are using Health Direct or interested in using Health Direct as a platform. We are the largest user of Health Direct nationally, so we do have and we are through with obviously Amelia joining the team as well, becoming that engaged consumer with Health Direct, and really pushing some of their technical capabilities and boundaries as well, where we can, to actually get the maximum value for health services. And there is quite a process that we do go through in terms of even development pipelines, etc., as well, and prioritization in terms of what health services do need, which are all discussed at the COP. So welcome participation and increased participation as we promote the use of Health Direct, and it is our positional view that it is Health Direct by default for us.
Great, thank you so much. I think that's super useful. Any final questions before we move to Olivia? And obviously, Chetna and Amelia have demonstrated how welcoming they are to our queries. So I would encourage you to follow up afterwards if you've got conversations that you don't have time for now, or prefer not to have now. I think one of the aims of this was really to start the connections. So please follow up on those as suits you. Now it's a real pleasure to introduce Olivia Metcalf. So she's a Senior Research Fellow and Behavioural Scientist at the University of Melbourne in the Centre for Digital Transformation of Health, and she leads a program of research into digital health. Thanks, Olivia.
Thanks, Anna. I'll just share my screen. Thanks, everyone, for joining me on a Friday. It was really great to present. Can you hear me okay? Yeah, it was really great to present alongside the Department of Health and to really hear about that overarching strategy, and yeah, so I really appreciate that. So I thought I could just take a little bit of time to talk about remote patient monitoring and some innovation around the evidence. And thanks for the acknowledgement of country already, and I just want to acknowledge that when we think about Australia's first people, we often think about how they were the first law and the first medicine and the first culture of Australia, but we don't often think about how they were also the first technology, and that's of course relevant today. This is Sandra Aitken. She's a Gunditjmara woman, which is the region of Western Victoria. And she's holding an eel trap that she's woven. And this technology is over 6,000 years old. So I just wanted to take a moment to celebrate that as well. Remote patient monitoring has a long history in healthcare. This is Alan Shepard. He's a NASA astronaut, and he is being remotely monitored in space more than 60 years ago. And obviously a lot of innovation has happened since then, although sometimes I acknowledge it feels like we're on a different planet at times. The initial innovation was really around heart failure, and I'm speaking mostly now about asynchronous remote patient monitoring. So recognizing that Chetna and her team have been talking about synchronous remote patient monitoring, which is occurring when a clinician and a patient are in the same consult at the same time. But there's been a lot of work as well around asynchronous, so when the patient is at home and monitoring their symptoms and managing their condition. So that was initially in heart failure, and by invasive, we mean the sensors were located internal to the body, but that's been expanded recently as technology has advanced. And now we typically think about remote patient monitoring in terms of sensors being external to the body. So that might be as simple as a smartphone or something, different types of devices, more complex, measuring different vital signs or monitoring different symptoms. And that's really grown in the last 10 years from heart failure to a range of different disorders. And there's now a huge body of evidence looking at how remote patient monitoring can be used creatively to help patients manage a whole range of chronic diseases, including things like diabetes, lots of different respiratory diseases. And of course, COVID-19 has been a big part of that, but also things like prenatal care, post-surgical care, dementia and aging, and falls prevention, a whole range of evidence. So I'll try to just give you a snapshot of that in like 20 minutes. This picture is very complex, so the key thing I want to take away is just really the different levels of remote patient monitoring, and again, kind of mapping onto what Chetna and her team were talking about. When we think about the patient layer, there's the need there for the technology, both hardware and software. Then there also is required digital infrastructure, so things like cloud computing and, sorry, just one second. Sorry, I just had someone at the door. That was bad timing. And then there's, of course, the clinicians involved in the algorithms and interpreting that information. And then at the back end, often there's integration with healthcare systems and other sorts of EMRs. So the kind of thing to take away here is the expertise that's required across science, technology, and clinical expertise in terms of RPM. And then the flip side of that, and this is a great picture from my colleague, Associate Professor Amelia, who was supposed to present, but she had to head back to Canada. She's been working in remote patient monitoring for 15 years in the Canadian health system. And you can see, even though the technology itself has changed a lot, a BlackBerry through to an Android that's being used for this particular heart failure program, the actual algorithm and the concept behind it is relatively unchanged, and it's been the same for 15 years. This is often what remote patient monitoring programs can look like. I'm sure you've seen a variation of this. And again, regardless of what disease is being monitored, the concept and the algorithm shares a lot of commonality. So a patient has their facing version, the patient application, where information is put in, and then they receive instant feedback. That information is also conveyed to a clinician. Here's one example of what that can look like. And underpinning that is this really important algorithm, and that algorithm is a rules-based expert system where the information is put in, and based on that information and individualized patient thresholds, the patient will receive an alert. For example, again, the Canadian system, this is what it looks like for them. Patients either receive information saying that their outputs are normal, or there's a need for caution, or there's a need for urgent care. And this data, again, comes from the thousands of patients who've been put through that program. And you can see 3/4 of the time, patients are receiving a normal feedback for this particular program. And then 1/4 of the time, action needs to be taken. And then less than 1% of the time, that includes some urgent or critical care. I just want to talk a bit about the evidence in the time we have. This is the last 15 years worth of research just into this one particular remote patient monitoring program, used primarily in heart failure, but also in a range of other, the management of a range of other diseases. And I think the key thing to take away here is, again, the amount of evidence that's been going on in this area. And so it can be hard to kind of boil this literature down, but I wanted to pick out 3 things that I hoped would be useful to you. When it comes to what constitutes success for remote patient monitoring, it's important to think about what outcomes we're trying to change. And there's lots of different outcomes with a remote patient monitoring program. One thing that might be really important to us, and typically is the clinical effectiveness of this program. So what I mean here is, does this remote patient monitoring program improve or reduce the symptoms of the disease that it's being used for? Improve clinical outcomes for heart failure or diabetes, or for aging, or whatever it might be. And then complementary to that, but not always connected, is also cost effectiveness. So what I mean here is that we might have a situation where something is clinically effective, but it's not changing costs, or also vice versa. So this is where remote patient monitoring, when it's introduced, is reducing the healthcare costs for the healthcare system. And it's also important to point out there's also a big range of other outcomes, and this is in no way comprehensive, but again, even if clinical effectiveness or cost effectiveness is or is not changing, there's also often changes associated maybe with quality of life, the patient's self-efficacy to manage a chronic condition, better or faster clinical decision-making, increased access to care and decreased inequity, and a lot of other measures. So I think, again, the key point to take away here is that these complex programs, when introduced, can impact a number of different outcomes, and it's important to think through from the start for us what constitutes success. I thought in the time I'd have, I'd just present some of the evidence that we've got currently. There is good evidence, might be relevant. So there is good evidence that remote patient monitoring programs improve symptoms of hypertension, COPD, and heart failure, but there is limited evidence that it improves this outcome from diabetes, which might sound surprising, but what we think is happening here, this is what the evidence is suggesting, is that diabetes by nature is a self-monitoring disease. So there's a need for the patient to be routinely monitoring their symptoms. So when we introduce a remote patient monitoring system on top, we might not be finding any kind of clinical outcome as a result. We're also finding mixed evidence around cost effectiveness, although there is good cost effective evidence that introducing a remote patient monitoring program relative to usual care is reducing costs for certain disorders like hypertension, COPD, and again, heart failure. There's also some interesting evidence telling us that you get more cost effectiveness, higher cost effectiveness when you're monitoring just one or two vital signs or symptoms, and that costs are increasing with complex monitoring programs. So that's something to consider and weigh into our decision making. But that also, I think, a really important point that really speaks so strongly to what Chetna and Amelia and her team have been talking about, which is that cost effectiveness is really dependent on that broader healthcare context in which it's being used. So things like organizational workflows and integrations are going to have this big impact. And it's certainly, not about just plonking an RPM into that. It's really, we have to kind of consider that when it comes to the introduction. This is not something, there's conflicting evidence around this, but I just thought it was interesting to highlight. There's some evidence that other different outcomes might not change in the direction we anticipated. So there's some evidence that remote patient monitoring, in some instances for some patients, might decrease their quality of life, which again sounds surprising. But what we're starting to learn here is that when it comes to putting data into the hands of patients who might not, or reducing access to care for certain patients for certain conditions, that might be having a negative impact. So I just kind of want to expand on that and talk a little bit more in the time we have about this concept that I think is quite a nice complement to this concept of digital maturity. So this is emerging in the literature. It's called digital readiness, and you might be familiar with it. But it's really a concept of how ready the health service is to implement a new digital program. So it can exist independently of digital maturity. And it's really kind of unpacked by thinking about both how ready the service is to implement the program, but also how ready and able the user or the patient is to engage with and kind of take advantage of that. So the literature at the moment is thinking about this in a number of different frameworks, but I think across the board, we're recognizing that a patient's knowledge and skills, their ability to self-manage their disease, their perceptions and mindset, including things like maybe their levels of emotional distress and their well-being, their experience overall with health technology systems, and the extent to which the patients are feeling supported by their network are going to be really having a big impact on whether that introduction of that virtual care program or that remote monitoring program are going to have a positive impact when we think about those outcomes. Here's one of the frameworks or the assessment tools that you can use. This is a relatively new one. I chose this one because well, I just chose this one because I think it had a great evidence base, but also one of the authors is actually a Geelong researcher. So I thought we have to represent Australia here. But I want to kind of acknowledge there are a range of ways you can do this, but they all take in similar sorts of concepts. And again, this image is kind of complex, but I think it does kind of neatly summarize the factors that are impacting digital readiness, how supported the individual is feeling, factors to do with the individual themselves, and then as well as their ability to access digital services. This kind of the complementary to that, so thinking about how digital readiness is important when it comes to the introduction of virtual care programs, and particularly RPM in terms of outcomes. This data from, again, our colleague in Canada, I think is really great. So this is data that she's collected, again, over thousands of patients in the heart failure program. And on the x-axis, you can see months since they were enrolled into this particular remote patient monitoring program. So this is over 12 months. And you can really clearly see that kind of common myth that we hold, that older Australians, or older people are less likely to use remote patient monitoring or complex virtual tools. They're more likely to drop out. You know, that is really, I think, debunked quite strongly in the evidence at the moment. There's an acceptance and an understanding that their digital readiness levels might be a little bit lower when the new program is introduced, but if we work with them in the way that they need and recognise the areas that they need to be kind of brought up in terms of their readiness, once that does happen, they have the highest levels of adherence to these programs. And actually the poorest levels of adherence, as you can see, is the youngest age group. So that's another nice way to kind of think about it in the context, I think, of deliver and kind of, complex virtual care programs. So all that sounds great, but I think we already know this, even with, this very robust user-centered design and implementation science that we're employing here, projects can fail, programs can fail. And again, this is data from the literature that I thought might be relevant. Why might a virtual care or remote patient monitoring project go sideways? We know that clinician buy-in and the readiness at the health service level, and particularly if primary care is involved, is really critical. I won't go through all of these, but I also just want to pick out low patient adherence, and I think this is really important to consider with remote patient monitoring. What is the value add of this? So again, this really speaks to that tension between what constitutes success with a remote patient monitoring program. If we're going into it because for us, say for us as a health service, it's cost effectiveness. That's the outcome. We have to still, put ourselves in the shoes of the patients and say, well, what is the value add for them and from their perspective? Do we have a good sense of what we anticipate metrics of success in terms of improvement? Or is this a situation in which we're putting, this isn't always the case, but thinking through where we're changing their care, we're putting, more expectation on them to monitor their own condition. And we know now the literature is telling us that some of those factors are, negatively impacting patient adherence to remote patient monitoring programs. So again, feeding back into that concept of digital readiness from both the patient and the health service provider perspective. And just in the last minute, and then I'll stop so we can have questions. We've been talking about kind of siloed remote patient monitoring programs, but of course, most of our patients, particularly older Australians, they have complex comorbid conditions. And so sometimes, single programs aren't well suited to that. This is something that's being trialed currently in the literature, again, from our Canadian colleagues. And it's just really focusing on the evidence showing us that overall nurse-led models of care are successful, and that perhaps remote patient monitoring programs can be kind of built into that. So a big study is going on at the moment in Canada, and we're really excited to keep an eye on the evidence and see what that tells us in terms of, learnings for Australia, but using a remote patient monitoring system embedded in the nurse-led model of care that can monitor multiple conditions, including heart failure, hypertension, diabetes, COPD, mental health, this real medley of conditions, and seeing if that improves outcomes across, those domains of clinical effectiveness, cost effectiveness, as well as kind of a broad range of other outcomes. So yeah, stay in tune, and as we hear these findings, I'll share them with you. But yeah, I'll stop now so we have time for questions.
Thanks very much, Olivia. That was a fantastic snapshot. And again, I'm sure there'll be lots of questions. If you want to stop sharing, then we can see everybody. And we've got a good 5 minutes for questions. So I do encourage you to ask some. Who's got a question for Olivia? Amelia.
Sorry, Anna, I couldn't find that. I'm
All good.
such a Teams person. I couldn't find my hand. Olivia, apologies if I did miss it, but I just wondered if you had any publications. I was really interested in some of the data that you were presenting, and keen to take that back to some of my colleagues, and I may have missed it. Apologies.
Yeah, no, I've been a terrible scientist researcher and I haven't put any of the publications I cited. Yes, I will pull up everything that I referenced in that and send it and share it with you. Yes.
Amazing. It will certainly help influence some discussions from my end, so that's great.
Yeah.
Thanks, Amelia. Other questions for Olivia? I just had a quick one. So, you know, in terms of your last slide around the SMART study, and I agree with you about nurse-led models of care, but I just wondered, it kind of also went a little bit against what one of the things you said earlier, which was the more things you monitor, the less likely you are to be effective and cost effective. So I just wondered if you could talk through, like, is there some kind of rationale built into the SMART program to alleviate that issue or not?
Yeah, that's a great question. So I should say it's not that they're, I don't know if I wasn't clear. It's not that they're not a cost effective, but just that I think the gains are, there's a larger initial investment when there's multiple complex conditions being managed, as well as kind of, I think, a higher amount of resources required to kind of monitor. The problem with the cost effectiveness data is that we really only have 12 or 18 months worth of cost effectiveness. And of course, for a lot of chronic conditions, that's not long enough to really measure how that's impacting hospitalizations and length of stay and other things that affect cost effectiveness. My sense is, the suspicion is that while you might have high initial cost for a complex program, if you implement it and monitor over a long period, you will eventually gain back the costs of that, you know, years down the line. I think that's my interpretation of it, although of course we'll need the data to speak to that.
I don't know if any of the health economists on the call, I think I saw Adam before. I don't know if you want to comment on that or if that's outside your realm, but I think you make a good point. Maybe we need the modelled cost effectiveness rather than the direct cost effectiveness.
I think almost all studies are only have 12, 18 or 24 month follow-up, which is, as we know, not enough for that. Sue, go ahead.
Yeah, so this is a little bit cheeky question, knowing that there's people from the Department of Health in the room.
Great.
I'm just wondering what the evidence is about paying the cost of monitoring. So the actual keeping the eye on the data that's coming in, and how the evidence suggests that the best way of doing that, because I know from many health services and clinicians that often that the cost of that has to be incorporated or taken out of other costs. But I'm just wondering what the evidence or what you know about that kind of thing, the monitoring, the keeping an eye on the when you need to act kind of things.
Yeah, I mean, thank you so much for that question. Did you want me to answer? I mean, I think this is the challenge with new models of virtual care, that I know for certain that it's not just Australia who's facing this. All of our kind of colleagues around the world have the same issue. What's the best reimbursement model for new virtual care? And at the moment, there's this tension between, old reimbursement models of healthcare adjusting to this new system. And we don't have my understanding is we don't have an answer for that. And I don't know,
Amelia or Chetna, did either of you want to speak to that? So that's that issue really of, you know, if you do have to, for example, pay a nurse to be the curator and that's not reimbursed within the remote patient monitoring program, are there ways forward on that?
Yeah, look, and I think that's it's a very real and relevant issue, and it's come up quite a bit in our consultation with the sector as well, and something that we're acutely aware of as we also look at funding models and how we kind of make it more sustainable as well as virtual care. We're hoping virtual care is not just a modality that's applied for the short term, but really the way you deliver care. I think there are some complexities obviously with different funding models and how we kind of keep up to pace, but there is a lot of consultation that we are doing with the Commonwealth as well as across other jurisdictions, is how do we make those models of care and those those funding models that are associated with it flexible and nimble to changing demands and changing needs. And the strategy that Amelia referenced to does provide some of that. It does speak to it, and it does provide some of that directional view of where we'd like to see some of that work heading and some of the challenges that obviously outside of our span of control and outside of our, scope of influence that we can hopefully work with the Commonwealth to try and resolve. But yes, it's an incredibly important issue.
Thanks very much. Appreciate that. And we'll take a look at the strategy. Any final questions for Olivia? Great. Look, thanks so much. If you could all join me in virtually thanking Chetna, Amelia and Olivia. I think that was really insightful and has given us all from our different perspectives something to take away. And I guess what I would say is, I mean, obviously the intent of Deliver is to engage all those multiple actors. So, researchers, policymakers, and of course the health service providers, to try and address some of these issues. And so I think we will continue this exchange, but if there are things that you're wanting to test from the department side, then I think we'd be really interested to hear that as well. And you've got a lot of willing, health services and a region that really wants to kind of build the evidence. So we might follow up some discussions with you on that too, which I think would be great. Great, well, just really to close the session, and thank you all for your attendance, and look forward to seeing you all on the next one. Thanks again.